Welcome back to the deep dive. Today, we're tackling a really critical area, the pharmacology of psychotherapeutic drugs. It's pretty dense stuff.
It really is. And, it's arguably one of the most complex fields in pharmacology because it's so reliant on, well, patient reporting and sticking with the treatment.
Right.
So our mission today is basically to boil it down. We want to pull out the core mechanisms, the main uses, and crucially, those high alert safety points you absolutely need to grasp from the source material.
Okay, so to get started, we have to touch on the basic theories, right? Yeah. The idea that mental disorders often stem from neurotransmitter imbalances.
Exactly. We're talking dopamine, norepinephrine, serotonin, and also GABA, the main inhibitory one.
And the text highlights two key historical hypotheses.
Yes, the biogenic amine hypothesis, the BAH, which originally suggested depression, came from too little norepinephrine. That kind of set the stage for trying to boost those amines.
Makes sense. And the other one?
The dopamine hypothesis. That one links psychoses, like in schizophrenia, to too much dopamine activity. So naturally, the first antipsychotics aim to block dopamine.
Understanding that really helps frame why some of the older drugs were developed the way they were.
Absolutely. And it's important context. We're not discussing, everyday sadness or worry here. These drugs are for prolonged, severe emotional or behavioral issues that really impact life.
And often require long-term care plus therapy. And then there's the whole issue of stigma, too.
A massive challenge, unfortunately.
Okay, so let's dive into the first major category then. Anxiolytic drugs. We've got the classics, the fast actors, but they come with downsides.
Right. You're talking about the benzodiazepines. Things like alprazolam, diazepam, lorazepam. They work fast for acute anxiety.
Yeah.
Yeah, and also for things like ethanol withdrawal or muscle spasm.
But
there's always a but. The but is significant. Even though they work quickly, the source material points out that antidepressants, SSRIs, TCAs, even MAOIs sometimes are often the first choice now for long-term anxiety disorders.
So why wait 4 to 6 weeks for an antidepressant to kick in instead of using something that works right away? Is the risk that high with benzos?
It really is. Benzodiazepines work by basically boosting the action of GABA, making that inhibitory neurotransmitter more effective. It calms the CNS down.
Puts the brakes on.
Exactly. But that quick effect also leads pretty rapidly to physical tolerance, then dependence, and there's a high potential for misuse.
And the side effects are essentially just too much of the intended effect, like CNS depression, sedation, falls.
That's a perfect way to put it. And the biggest safety flag is mixing them. Combining benzodiazepines with alcohol or opioids or any other CNS depressant is incredibly dangerous.
Okay.
Overdosing on benzos alone, rarely fatal. But add in alcohol, that can quickly lead to respiratory arrest.
And if we need to reverse it, like after sedation for a procedure, flumazenil?
Flumazenil, yes, it's a benzodiazepine receptor blocker. But, and this is critical if someone's been taking benzos long term, giving flumazenil can actually trigger a really severe sudden withdrawal seizures, the works.
Wow. Okay, not straightforward then.
Definitely not. It's a high-risk intervention in dependent patients.
Which makes the alternative, buspirone, sound a lot more appealing, though it works differently.
Buspirone is interesting. We don't know its exact mechanism, but it seems to work on serotonin and maybe dopamine receptors. The huge advantage, it doesn't have that sedation or the dependency risk like benzos.
But it's not for as-needed use.
Correct. That's the key difference. It has to be taken on a regular schedule to be effective. It requires patience from the patient, definitely. It doesn't provide that immediate relief.
Okay, moving on. What if the problem isn't just anxiety, but the big swings of bipolar disorder? That takes us to mood stabilizers, and the main player is lithium.
Lithium is still foundational for managing acute mania and for long-term maintenance in BPD. Mechanism-wise, it seems to mess with sodium transport in nerve cells and also affects how catecholamines are metabolized.
And this is where the monitoring becomes absolutely paramount, that narrow therapeutic index.
Extremely narrow. We're aiming for maintenance levels roughly between 0.6 and 1.2 millimole. It's a tiny range. And the link to sodium is fascinating and critical.
How so?
Basically, the kidneys can mistake lithium for sodium. So if a patient gets dehydrated or their sodium levels drop hyponatremia, the kidneys try harder to hold on to sodium.
And they grab the lithium instead.
Exactly. So lithium levels shoot up, increasing the toxicity risk dramatically.
So telling patients not to suddenly change their salt intake or fluid levels isn't just casual advice, it's vital.
Absolutely. Life or death advice. Toxicity starts showing up around 1.5 millimole, mild things like tremor, maybe some GI upset.
Hmm.
But above 2 millimole, you're looking at severe confusion, seizures, and the most dangerous outcome, cardiac dysrhythmias.
That's serious.
Very. And patients need to know that common drugs interfere too. Thiazide diuretics, ACE inhibitors for blood pressure, even things like Advil or naproxen NSAIDs can all push lithium levels up.
Wow, it's a lot to keep track of. Okay, let's shift gears to antidepressants. There's kind of a generational story here.
There is. But across all classes, the first big point is the time lag. It usually takes 4 to 6 weeks to feel the full benefit. That wait can be really tough for patients.
Leading to stopping the med too soon.
Often, yes. Which is why the text emphasizes starting treatment early and being aggressive enough to aim for full remission, not just partial improvement.
And we absolutely have to talk about the big warning sign right up front, the Health Canada black box warning.
Yes, this is critical. The warning highlights an increased risk of suicidal thoughts and behaviors and agitation, especially when starting the medication or changing the dose.
Why then?
The theory is that the medication might give the person a bit more physical energy before their mood actually lifts or their hopelessness improves. So they might have the energy to act on suicidal thoughts during that window.
That's a really important counterintuitive point. Requires constant vigilance.
Constant monitoring, absolutely.
Okay, let's look at the first generation antidepressants, the tricyclics, TCAs like amitriptyline. They block norepinephrine and serotonin reuptake, still used sometimes.
Yeah, but mostly for other things now, like neuropathic pain or sometimes insomnia. Their big historical downside is just terrifyingly significant.
The overdose risk.
Exactly. TCAs are notoriously lethal in overdoses. The source mentions figures like 70–80% of fatal TCA overdoses happen before the person even gets to a hospital, usually from seizures or deadly heart rhythm problems.
Okay, so definitely not a first choice for someone at high suicide risk.
Absolutely not. And they also have those annoying anticholinergic side effects, dry mouth, constipation, difficulty urinating.
And the classics,
Yeah.
and the other first-gen class, MAOIs.
Monoamine oxidase inhibitors, used even less often now, really only for depression that hasn't responded to anything else. And that's because of the risk of hypertensive crisis.
The cheese effect, triggered by tyramine.
Right. Found in aged cheeses, cured meats, some beers and wines. But also, interactions with common over-the-counter cold medicines can trigger it too. There's a sudden, dangerous spike in blood pressure.
So requires major dietary restrictions and caution.
Huge caution. And you need a washout period like 2 to 5 weeks. If switching between an MAOI and another antidepressant like an SSRI to prevent dangerous interactions like serotonin syndrome.
Okay, that brings us nicely to the second generation, SSRIs and SNRIs. The modern workhorses?
They are. They're first line now mainly because they're generally safer and have fewer side effects than the older drugs. SSRIs, selective serotonin reuptake inhibitors, like fluoxetine, mostly just target serotonin.
And SNRIs.
Serotonin norepinephrine reuptake inhibitors, like duloxetine. They hit both serotonin and norepinephrine.
Safer, yes, but not without issues that affect people actually taking them, right? Things that make people want to stop.
Definitely. Insomnia can be a problem. Weight gain is common with some. And a big one is sexual dysfunction, particularly difficulty reaching orgasm. That's a major reason people discontinue.
Understandable. And we mentioned serotonin syndrome briefly. Need to unpack that a bit more.
Right. It's rare, but potentially life-threatening. It happens when there's way too much serotonin activity in the brain, usually caused by combining drugs that boost serotonin like an SSRI with an MAOI, or even with the herbal supplement St. John's wort.
What does it look like?
It's a collection of symptoms. Sudden confusion or delirium, agitation, really fast heart rate, high fever, muscle rigidity, or spasms that twitching called myoclonus, needs immediate medical attention and stopping the offending drugs.
Okay, got it. Last major group, antipsychotics, for severe conditions like psychosis, schizophrenia.
That's right. The core mechanism for all of them involves blocking dopamine receptors, specifically the D2 type. The older ones, the conventional or typical antipsychotics, mainly just block D2 receptors after the synapse.
And the newer atypical ones, like risperidone.
They also block D2, but they also block certain serotonin receptors, notably the 5-HT2 type.
And that difference matters because...
It significantly changes the symptom profile they treat. Conventional drugs are pretty good at controlling the positive symptoms, hallucinations, delusions, disorganized thinking.
The things most people associate with psychosis.
Exactly. But the atypical drugs often also help with the negative symptoms, things like apathy, lack of motivation, social withdrawal, flight emotions. And those negative symptoms are often what cause the most long-term disability and difficulty functioning.
That's a huge advantage. But antipsychotics have their own major set of risks, particularly movement disorders.
Yes, the extrapyramidal symptoms, or EPS. This is a huge historical concern. Think of it like drug-induced Parkinson's disease,
Mhm.
tremors, muscle stiffness, a shuffling walk. Also akathisia, which is this horrible inner restlessness and inability to sit still, and acute dystonia, painful muscle spasms, often in the neck or eyes.
Very unpleasant, sounds like. And then there's the really feared long-term one, tardive dyskinesia.
TD, yes. This usually appears later after longer-term use and can sometimes be permanent even after stopping the drug. It involves involuntary movements, typically of the face and mouth, lip smacking, tongue thrusting, chewing motions, and sometimes writhing movements of the limbs.
Do the atypical drugs have less risk of EPS and TD?
Generally, yes. That's one of their main advantages. The risk isn't zero, but it's lower than with the older conventional drugs. However, we also have to mention neuroleptic malignant syndrome, NMS.
Another rare but serious one.
Very rare, but life-threatening. High fever, extreme muscle rigidity, unstable blood pressure, and heart rate. It's a medical emergency.
And the atypicals, while better for movement disorders, brought a new problem, right? The metabolic issues.
That's right. A significant concern, especially with some like olanzapine or clozapine, is the risk of cardiometabolic syndrome. This means significant weight gain, developing insulin resistance or even type 2 diabetes, and unhealthy cholesterol levels.
So trading movement issues for heart disease and diabetes risk, potentially.
It's a major trade-off to consider and monitor closely. Regular checks on weight, blood sugar, and lipids are essential with atypicals.
And speaking of close monitoring, clozapine needs special mention. Effective for tough cases, but requires intense oversight.
Extremely intense. Clozapine has a unique risk of causing a granulocytosis, a dangerous drop in white blood cell count, leaving the patient vulnerable to infections. Because of this, patients must have their white blood cell count checked weekly for the first 6 months of treatment and regularly after that. It's mandatory.
Non-negotiable. Wow. Okay, pulling this all together for someone learning this,
Yeah.
what are the absolute key nursing process takeaways? Assessment essentials.
Baseline assessment is everything. You need a good neurological exam, maybe a cognitive screen like the Mini Mental State Exam, MMSE. Vital signs are crucial, especially checking for postural hypotension that drop in blood pressure when standing up, because so many of these drugs can cause dizziness and falls.
And we already touched on it, but suicide assessment.
Cannot be stressed enough. It has to be ongoing. Use structured tools if available, like the IS-Path warm mnemonic the text mentions, looking for ideation, substance use, purposelessness, anxiety, feeling trapped, hopelessness, withdrawal, anger, recklessness, mood changes. And always remember that high-risk window we talked about, when energy returns before mood lifts.
Important considerations for specific groups, too.
Definitely. Older adults generally need lower doses. They're more sensitive to side effects like sedation, anticholinergic effects, and the fall risk is higher. Also, ethnocultural factors matter. The text notes, for example, that people of Asian descent might metabolize some benzodiazepines or TCAs more slowly, needing lower doses to avoid toxicity.
And patient teaching. Adherence is key.
Absolutely. Stress taking meds exactly as prescribed. And critically, warn against stopping abruptly. That can cause withdrawal syndromes or rebound symptoms. Help them manage common side effects too, tips for dry mouth, constipation, and being open about discussing sexual side effects.
Okay, we have covered a massive amount of ground, from neurotransmitter theories to benzos and their dependence risk, lithium's narrow window, the TCA overdose danger, serotonin syndrome, antipsychotic movement disorders, and metabolic risks. It's a lot.
It really is. It highlights how complex managing these conditions pharmacologically is. Lots of balancing acts, careful monitoring, often finding the right drug involves some trial and error based on efficacy and side effects.
Which leads perfectly into that final thought.
Right. This chapter paints a picture of our current approach. But thinking ahead, especially with how common it is for people to have, say, both anxiety and depression, how might pharmacogenomics change things? The study of how genes affect drug response. Could that eventually move us beyond this trial and error phase described here? Could we tailor drug choices right from the start based on someone's genetic makeup?
A really interesting and frankly hopeful question for the future of treating mental health. Thank you so much for walking us through this incredibly important, though challenging material.
My pleasure. It's crucial knowledge. Stay curious, keep learning.